Okay, all the things I screwed up today studying for boards, so you don't have to. Number one, what is the antibody for granulomatosis with polyangiitis, aka Wegener? C-ANCA, aka anti-PR3. That's the part I got wrong because I know C-ANCA, but I didn't. That's just not okay. And for Wegener, remember it's some sort of head issue, some sort of rhinitis, sinusitis, and then hematuria. Kiddo has a really, really high fever and then maybe has a couple febrile seizures. Everything resolves, and then a couple days later, they get a rash. What do they have? It's roseola. What does it cause? By HHV6. I put the wrong number. Okay, a girl has mono. She's 19, and they put her on like spleen watch, all the things, right? Okay, what is she at risk for later? She's 27 now, and she has B symptoms. She has some like cervical swelling, cervical lymphadenopathy. Um, Maybe she has some owl eye inclusions on histology. Hodgkin lymphoma. Okay, it's going to put you at risk for that later. Okay, a guy has paroxysmal supraventricular tachycardia, and so he's due for an ablation of whatever the ectopic foci is in Crista terminalis. Who cares? Okay, it's in the right atrium. The question was, what nerve are you at risk of nicking? So what is around the right atrium? So it's going to be the right phrenic nerve. And how will you know if you nicked it on X-ray? What are you going to see? The right side of the diaphragm is going to be elevated. Okay, because obviously you can't use it. Okay, I'm going to say the disease and you're going to tell me what's the defect. Hyper IgM syndrome. What's like the cellular defect? CD40L, because the two cells can't connect and then pump out different immunoglobulins. Okay, SCID. A couple of different answers. So the main one is IL-2R gamma chain, which I always forget because I don't know why I remember that adenosine, I believe it's adenosine deaminase is the one that's fucked up too, but it's pretty rare to have that one. The IL-2 gamma chain is much more common, apparently. Okay, what about X-linked agammaglobulinemia? What's fucked up? Tyrosine kinase, and that's going to happen around what age for the baby? About 6 months or after. Why does it take around 6 months? Because before then you have mom's immunoglobulins, right? Okay. If you have a fucked up list gene that doesn't work and the microtubules don't work, what disease is that? Chediak Higashi syndrome. Remember, it's like the cell will eat the bug, but then it can't like engulf it because the microtubules are screwed up. What about the WAS gene mutation? It's kind of an easy one. It's in the name. It's Wiskott-Aldrich syndrome, but what's the problem? What is the mutation cause? The cytoskeleton's fucked up. Okay. If you have a baby that has a delayed separation of the umbilical cord, what are some options of issues? So it could be cystic fibrosis or leukocyte adhesion deficiency, which is an autosomal recessive defect. What's fucked up? CD18, also called the beta 2 integrin. So that means that you're going to have all these leukocytes all over the body, but they, like if you cut yourself, normally once the body's going to say, hey, come over here, we need you, they can't migrate over there. They can't get over there. Okay. All right. You have a left sided facial droop. Okay. What are we thinking immediately? Two things: stroke and Bell's palsy. How are you going to know if it's a stroke versus Bell's palsy? What are you going to see up here on the forehead? Okay. If it's a Bell's palsy, it's going to be a complete droop. But if it's a stroke, it's going to spare the forehead. So you'll still have like forehead wrinkles, not with me with my Botox. You're still going to have your forehead wrinkles when they raise their eyebrows or if they can raise their eyebrows because the forehead has like two connections. So it's serviced by another area. Remember the area. If you do, comment it below. Okay. There is a 16-year-old female, altered mental status, fever, hyperreflexia, headache. On MRI, you're going to see hyperintense lesions in the temporal lobe. What's the diagnosis? It's HSV encephalitis. And remember that HSV and temporal lobe are like married. Okay. If you just see the temporal lobe, I'm just automatically thinking HSV. What's the treatment? It's IV acyclovir. That's not where I fucked up. What do you give the close contacts? Nothing. I think I gave them, I don't want to talk about it. Like, I don't know if I gave them rifampin. Who knows what I did to these people? Who knows? But give them nothing because apparently HSV encephalitis isn't, it's not like Neisseria meningitis where everyone's freaking out. Okay. If you have crazy hypertension and then they see on CT you have an intracerebral hemorrhage, you're going to have damage to what arteries? Lenticulostriate arteries. If you're walking down the street, get hit by a car, and then you have an epidural hematoma, you're going to have rupture of the blank artery. Middle meningeal. Okay. And bipolar mania treatment, acute, you can give them what? Oh, lorazepam. Calm down. What about long term? Lithium, valproate, lamotrigine, lots of options. Okay. But remember, they all have like their own different contraindications, but those are just some options. I believe the lorazepam was the question. And then just back from yesterday, I gave this one yesterday. What is the most common brain tumor in adults that's just thin onset? It's a glioblastoma multiforme. And is it aggressive or chill? It's very, very, very aggressive. And it crosses the midline. It looks like a butterfly on CT, they say. So I like to think like float like a butterfly, sting like a bee because it's very aggressive. It comes from astrocytes. Okay. And on histology, you'll see pseudopalisading necrosis with vascular proliferation. It's a mouthful. Okay. But I think a lot of the times when they give you a glioblastoma, they really like to put that CT on there. Like it's big. Okay. Leukemia is a weak spot of mine. I don't know why. I think that I feel that it's so much more complicated than it actually is just because I don't know. It seems like a lot, but it's not. Okay. So acute leukemias are going to have a shit ton of what kind of cells? Blast cells, because it's acute. They're all popping out. Okay. And I know that with ALL, like acute lymphocytic leukemia, that they have that marker. It's TDT. I don't know why it reminds me of like Ninja Turtles. It's not, but that shows that it's an acute leukemia. Okay. If you have a myeloid leukemia, it's going to be in the neutrophil line, like basophils, eosinophils, like the granulocytes. The treatment is imatinib. It's going to target what? The BCR ABL fusion protein. It's a tyrosine kinase. And you can confirm that it's a CML because you'll have the Philadelphia chromosome. It'll be a what translocation? What are the numbers? 9 and 22. All right. And just to finish it out, what is a leukemoid reaction? This one threw me. I don't know what I was thinking. Okay, so Melman likes to say oid, OID, is looks like but ain't, which I like. So it looks like leukemia but ain't, meaning the WCs are like crazy high. But how do you know if it's a leukemoid reaction versus actual leukemia? You have to look at what? The ALP. Because if it's a leukemoid reaction, the ALP will be elevated, but in CML it will not. I got this question and it literally was this huge long thing. I was like, this person has leukemia, leukemia, leukemia. And at the very end, it was like ALP was not elevated or was elevated and it was leukemoid after all that. I was just like, okay, it wasn't even a number, it was in the sentence. So I should have known. But all right, that's it. Happy studying. Thanks for the 3 people who watch this. I really appreciate it. And the 2 people who save it. If it's my mom, love you.